and welcome to today's episode of Focus on Health. My name is Yvonne Kemuma, and as always, it is a pleasure having you on the episode. Today we are discussing cancers, particularly lung cancers. What are they and what are the predisposing factors? We dive right in. We begin with the health update.
Hello everyone, my name is Dr. Tracy and Wanjiru. I am a consultant clinical oncologist currently working at Kenyatta University Teaching, Research and Referral Hospital. So lung cancer is basically abnormal cell growth in the lung. It can be either in the lung or the bronchus, but this is what we call lung cancer. Why lung cancer is important? In Kenya, it's not top 5 cancer, but it is the first or the most fatal cancer we have around the world. And this is why it becomes very important for us to speak about it so that we can know about awareness, we can know about the kind of equipment that we have and the strides that we have made in terms of treatment. Yes, definitely lung cancer has types. It's important to also know the different types because treatment modalities are a bit different. So we have 2 types mainly. Non-small cell lung cancer. This is the one that is very common, that we commonly see. About 85% of the patients have this. It is more slow growing in terms of the outcome. Then we have the small cell lung cancer. It's rapidly growing, and unfortunately most of the patients already come in stage 4 with this kind of cancer, but it's less common that we see. I think one of the things, even when we were doing med school back in the day, it was thought to be only a smoker's disease. But what we are seeing now is that lung cancer actually affects a lot of non-smokers. And this, of course, has come with other predisposing factors. So we are going into what we call precision medicine. So we are trying to find out what is causing cancer and can we be able to target these causes of cancer. So there is what we call genetic alterations that can also cause lung cancer. The main one being smoking, the second one being pollution. First, there is second-hand smoking. So if you smoke a cigarette with someone around you, that person is a second-hand smoker. The other one is pollution. So indoor pollution is very common in our society because a lot of us share the same space with a kitchen and has firewood, some kind of biomass fuel. So either firewood or charcoal, and you are inside. So indoor smoking. Outdoor smoking is more common in the West, outdoor pollution, but this is something that we still see. Other chemicals like asbestos that has completely been banned is a risk factor for lung cancer, but these are the main things that we definitely know. But tobacco is number 1. Definitely, that's true. Because you see, a cigarette has a filter. So when a person is smoking and they have a cigarette and it has the filter, they're actually getting filtered. But you who is there, you're smoking all the carcinogens that they are. So yes, secondhand smoking is a big risk factor for lung cancer. For smoking, cigarette smoking, it's tobacco, but also the smoke in terms of firewood has some carcinogens, okay? In terms of, especially when firewood is wet, there are some barks of trees that have been shown to actually have some carcinogens. So these are the ones that we really look out for indoor smoking. So what we are pushing for now is if you have a kitchen and you need to use your kitchen, have it as a separate room that you can do your firewood in one room and you're sleeping in another room. This is quite important, and this is what we are pushing for, or even just the number of windows that you have as the rural setting kind of housing. It's important we talk about symptoms. The biggest challenge with lung cancer is that it's silent. And that's why most patients come in stage 3 and 4, because it's a very silent disease. By the time you're having symptoms, something else is going on. So the main symptom that you see is blood, coughing up blood. So coughing up blood is usually, for us, most of us, it is something that we really look out for. The biggest challenge in our society is that we have TB. TB has almost the same symptoms as lung cancer. So sometimes we have patients who go to TB clinics, they stay there getting anti-TBs, yet they have a cancer which is going to be recognized when it's already late. But most of the symptoms are very, very similar to TB. So there is coughing, chest pain, hoarseness of voice. There are patients who come in stage 3 and 4. I actually have a patient who presented with syncope. This is just fainting. He would faint all the time. Unfortunately, the lung cancer cells had gone to his brain. So yeah, these are some of the symptoms that we see, but coughing up blood is something that a lot of us know as a symptom of lung cancer. And I think one of the things that we are really doing as oncologists is CMEs. The people who man TB clinics are really either medical officers or clinical officers. So what we are trying to do is education. I think CMEs and awareness about cancer. As I said, lung cancer is not very common in our society, but it's still there in our society. So it's something that we are trying to do in terms of just teaching them the algorithm, teaching them which other testing that should be done, especially if a patient has been on anti-TBs for a long time, they're not getting better, then we need to move on to another kind of scan or something like that. Yes, I think one of the things that we are really doing as a referral hospital, it's a level 6, so most of the patients come here for treatment. One of the things that we're doing is awareness. We do awareness and we know that screening is available. Now, screening for lung cancer is being done in other countries in mass, where lung cancer is very common. In our country, we have other common cancers that we're trying to take care of first. But one of the things that we do in terms of screening, if you are what we call a high-risk person, so you are a smoker and you have smoked for many years. So smoking also depends on how many years you smoked and how many cigarettes you smoke per day. So this actually depends. So if you're a smoker and above the age of 40, you're at high risk, you should do what we call low-dose CTs. So low-dose CTs is a CT scan that is available at KU. You can come and walk in and say, I think I need this kind of CT, and we can screen you for lung cancer. So this is one of the ways that we screen for lung cancer. It's not a common modality and it's not something we are doing at mass, but this is available. For now, the main people we are really targeting are smokers, because tobacco is known to cause lung cancer. But of course, we are asking that even other men should come in for screening. Of course, we are starting with other cancers first. As I said, it's not common. Of course, if you have any kind of symptomatology, then you have to come in. We need to start all the scans and see whether there is something like this. Unfortunately, lung cancer is very silent. Most patients will definitely come in. So of course we have challenges. I mean, we definitely have challenges in terms of some of the equipments that we have, how many oncologists that we have. These are some of the challenges we have in our country. But one of the things I think is awareness. People need to know that this cancer exists. As much as it's not very common, it is actually number 1 in terms of fatality. So like, when we have 100 patients, 90 will actually die from the disease, and this is a high percentage. So because of this, it is something that we are really pushing for. So awareness to stop stigma. I think also we have a lot of cancer stigma. People are very worried about the C word. So to stop stigma amongst ourselves, support someone who has lung cancer. This is where it starts. And also give yourself knowledge. I think people also don't have enough knowledge, and this is available on just you can be on your phone and you can see. So some of the signs and symptoms are written, some of the risk factors are written, but number 1 is definitely stop smoking. I think this is one that really as a country we can push, that we can all stop smoking, because we know cigarette smoking has this challenge. We need to streamline our efforts, especially for screening. Yes, again, we screen mainly when there is a World Cancer Day or when there is breast cancer or prostatic cancer. So what we are really pushing for is that people should be screened at least once a year, annual health screening. And it's not only about lung cancer, all cancers can be screened. We are able to do a lot of screening depending on your age, your risk factors. So one of the things is that we have tools that you can fill in your risk factors, then we see what kind of screening really suits you. So more of a screening depending on your risk factors. Yeah, so it's personalized kind of screening. But yes, I agree, we need to do more screening. I think a lot of hospitals, if you walk in and ask for screening, they will do what they can, meaning some blood tests and this kind of thing. But for KU, I think we have months that we do different screening, and this really helps. But for things like breast cancer, because this is the most common cancer we have in our country, we are 24-hour, there is a breast cancer comprehensive area where you can come in for screening and you'll get treatment if you need it.
Okay, we are due for our first break on the episode. Then as we get back, we'll be diving more into this topic. So keep it KUTV's Focus on Health. Welcome back. My name is Yvonne Kimuma. Keep us engaged on our socials on X at KUTV Kenya at Kimuma_Monari. We continue.
What we know, so we have what we call WHO classification of carcinogens. Tobacco smoke is in WHO 1. Okay, so this one has been proven, has been shown to cause lung cancer. Now, things like weed smoking, this we do not have enough data to actually ascertain that it does cause lung cancer, but definitely shisha, unfortunately, is a causative of lung cancer. The other one is vaping. So vaping has been shown to cause chronic inflammation, and as we know, chronic inflammation is one of the causes of cancer. But of course, we need more time to get more data to bring to you exactly what the percentage looks like. I think one of the things that we need to also acknowledge is most of the patients I see do not come through screening. These patients have symptoms, and most of them have had symptoms for years, and now the cancer has been found. So some of the things that we do that especially must be done is a biopsy. So a biopsy basically tells us that yes, these cells are abnormal and these cells need treatment. This is where most patients will start. Unfortunately, the procedure of getting the biopsy is also very specialized, because you need something to pass through either a bronchoscopy, we call it, or you need to do a CT guided biopsy. So sometimes most of these patients will have to get to be referred even just for a biopsy. So after biopsies, we do now the usual scans to stage the disease. Unfortunately, a lot of our patients are in stage 3 and 4. I mean, in terms of cancer, we have about 80 to 90% of patients are in stage 3 and 4, not only lung, even the other cancers. So after that, now we go in through the treatment modalities. So one thing about lung cancer that we need to acknowledge is that we have moved from blanket treatment to what we call precision medicine. Precision medicine means that we treat you according to what you have. No two lung cancers are the same. The biology is totally different. So we treat you according to the biology. So nowadays we are going into what we call molecular profiling. This is very important, and this is available here at KU. It's something that we are doing on the daily. So molecular profiling, we are able to see what molecule is causing your lung cancer to grow faster, so that we can give you a drug to stop it, essentially in layman's term. Okay, so molecular profiling is one of the things we do. Another kind of treatment we have is immunotherapy, and this helps your own immunity to fight the cancer cells. Unfortunately, these treatments are not cheap, but one of the things that maybe we have been able to do, and pharmaceuticals have been able to provide, is, for instance, molecular profiling now is being done for free, just because you are from KU, from a public facility. And a pharmaceutical is providing this for free, and the drug is also at a lower cost. So they do what you call a financial assessment and see how much you can be able to afford, and this is what they give you the drug for, this much, how much money. And this has really changed the landscape of lung cancer. 5 years ago, this was not even available. Even the molecules were not available, and now we have all sorts of molecules available. We have immunotherapy available, SHA is also very important in this way. SHA has also increased the rebate, and because of this, at least more patients are able to get more cycles of the treatment. Of course, not enough, but a bit more. And this has definitely changed the outcome. Yes, so prognosis, this basically means how long you're expected to live in the stage that you are in. So it highly depends. If you're in stage 1, your prognosis is quite good. But if you're in stage 4, then the prognosis is poor. And poor, I am saying about 20 to 30%. This is quite low to what is apparently in stage 1. And stage 1, they're going all the way to 70%. Of course, accessibility to treatment and all these things matters. So for stage 1 and 2, we are able to do surgery. Some patients actually undergo surgery to remove the whole lung, and this is called lobectomy. This is available. For stage 3 and 4, most of the patients will need maybe some radiotherapy, some chemotherapy, and now the other target therapies that we are doing a lot for stage 4. Unfortunately, most of the patients come in this late stages, mainly because of the referral pathway, but because also the symptoms are really, as said, it's silent. So they come when they already have maybe brain metastasis, or they're unable to walk, so they have bone metastasis. So these patients now need timely intervention to be able to help them recover. But the prognosis has really, the landscape has really changed with this new therapies available. And I think one of the things that we need is what we call patient navigators, that if you get a patient who is having symptoms in Lodwar, someone should be able to ensure that they get a biopsy, they get the scans, and they get the treatment within a certain time. Our main challenge is not also just the referral pathway. Our main challenge is also finances. Cost of coming to Nairobi is expensive. Cost of somewhere to stay in Nairobi is expensive. So the challenges that we have as a country are not just because of the referral pathway. There is also financial burden on these patients. There is also a lot of stigma when you get this diagnosis. There is also lack of meds. Sometimes you cannot access the medication. You cannot access even that biopsy I'm talking about. So some of these things are what we need to change. So we are talking to policymakers and asking them that they look into this, because at the end of the day, lung cancer is still #1 cause of death in cancer. I would say we've come a long way with SHA. I think now we are a bit better, not yet there. Cancer treatment is expensive, and cancer is not only about treatment. There are so many hidden costs. There is cost of living in a different town. There is cost of coming to hospital every day. There is food. There is accommodation. There are so many hidden costs. So yes, SHA is able to cover some part of diagnosis, not all of it, some part. In terms of treatment is expensive. So you will find that the 880 that has been given as a SHA rebate, the patient will probably use it only for 4, or even depending on the kind of treatment, especially with immunotherapy, maybe for 4 cycles only. And for these patients, we continue with the cycles through and through. So at the end of the day, it's not yet enough, but it's much better than what we had previously. I think in terms of treatment, again, treatment is one of those things that we research every day. So new treatments are made on the daily. There is still a lot of treatments we are not yet able to access, mainly because either of cost, or also, remember, these pharmaceuticals need licensing to bring this treatment into our country, which takes a bit of time. But one of the things that I must say, molecular profiling is something that is the next, it's like the future of lung cancer. All patients must have a molecular profile, because that tells us which drugs these patients will respond to best. Now, one of the things that we need to do is what we call next generation sequencing. This machine, we are still trying to purchase it as KUTRRH, but it is available at different private facilities, and it's able to give us the molecular profile of the patient. So a lot of NGS we are still sending outside. Another thing is robotic surgery. I think this is the future. This is where a lot of medicine is going. So robotics is not yet in the country, but we are sending some patients abroad who require it to get robotic surgery, just because of access to the area that we need to do surgery. Of course, in other things, in terms of the number of oncologists, number of nurses, number of lab techs, the whole spectrum. I mean, when it comes to capacity building, we are still very low in terms of capacity, that we could definitely do better. Number one, stop smoking. I think this one I cannot emphasize enough. Indoor pollution, what we are asking is that patients or people always have a very airy room. If you need to cook with firewood, if you need to cook with a jiko, you either do it outside or have a very airy room. Another thing that we are doing, as I think the government is doing, is looking at the carbon footprint of our cars. This is something that is really being out there, especially in the West. They're really looking at carbon footprint to try and reduce emission that comes from our vehicles. Thank you very much for having me. It's very important that we keep on speaking about cancer. I really believe when we talk about it, we destigmatize it, and this is where we want to go. In terms of lung cancer, I would ask you to come in, just equip yourself with some of the signs and symptoms that you see. Also educate your community. Educate your community about the risk factors we've spoken about and what you need to do to be able to avoid some of these risk factors. Always remember, treatment is available. We have all sorts of treatments available. A lot of us are waiting for you. Just come in if you have a diagnosis of lung cancer. We will walk the journey together. Thank you very much.
It is a wrap. Thank you so much for keeping it KUTV's Focus on Health. Until next time, same place. My name is Yvonne Kemuma. Engage with us on our socials at KUTV Kenya at Kemuma_Monari. I leave you with the Healthy You segment.